So among the many questions that we raised, I think there are two questions that he leaves us with. One is, with the introduction of universal health coverage, will the rich continue to benefit at the expense of the poor, or will UHC live up to its ideals of ensuring that there is access to everyone when it is needed, where it is needed? Another last question that he leaves us with is the issue of demand versus supply. Will we meet the demand for healthcare once these programs are introduced, or will we end up rationing provision through long queues, issues such as long queues? So those are some of the questions. Now the floor is open for all of us to raise questions.
My name is Steven Chiworo. I'm working for NAMA. We don't have time. Maybe let me paint a picture the way how I see things. 2018 National Health Accounts reports that Namibia collected 15 billion for the healthcare provision. That money was structured as this. 6.5 billion was the allocation by Minister of Finance to Ministry of Health and Social Services. The same minister allocated 2.5 billion for those that are working for government to CMAS. Another component which Dr. Kandetu touched on was the medical aid funds, the umbrella of which, or the regulator of which, is 10% of our population. And then the 6.5 billion, which is money available to the entire country, including people of CMAS and those that belong to medical aid funds, should they find themselves where there are no services or private services available, is only having 6.5. And that's money that Dr. Kandetu wouldn't dare touch on ED tonight. Dr. Kandetu will be throwing his salary. Not as a practitioner, but as an administrator. So take that 6.5 billion, split it amongst the people that work for that ministry, and see how much is remaining. Do we have a problem in this country, or don't we have a problem? Let me also add to that, Madam Moderator. The Abuja Declaration, these people would know better, calls for each and every government to allocate at least 15% of their budget towards healthcare. Namibia is the only country in Afro region, this southern hemisphere, that Afro's, there is a name for that thing, that is closer to that 15%. 30% of our budget goes to our healthcare, government budget. But our health outcomes is poor. So the question is, if you are thinking universal health coverage, do you think of using the money that you have? Let me pause. Another question. This 15 billion, economist is here, is available to 2.6 billion people in the country. That 2.6 billion, 38% of are people the age under 18 years. Very healthy, who would not be taking on so much of your health care. Meaning that you are only sitting with 60% of the population of that 2.6. That draws from that 50 billion. Now, questions. The healthcare financing policy we don't have should be the guide that ought to direct how that money first is going to be collected. I see Mr. Kenjele is talking about creating a fund. Do we need more fund, or do we need to allocate our resources efficiently? Is it a question of pooling? Now, between Mr. Kenjele and Dr. Kandetu, we are talking about health, UHC. That is a combination of healthcare services and financing of that healthcare services. But we seem to be confusing these two concepts so much that a person that ought to be pooling those resources is now seen to be competing with that ought to be making policy for the healthcare that needs to be available in the country.
I want to mention two examples of where I felt proud about the Namibian public healthcare system before I pose my two questions. First one was, I was managing a crisis where a gas bottle exploded on farm Tari outside of Dortabes, and about 12 children burned, 60 to 80 degrees burns, and they were brought here by ambulance. The same night, these children, farm workers' children, were taken to the best facilities that we have in Namibia. Private, the Medicities, the Rhino Parks, and wherever. And this was on government expenses. I'm dreaming for a day where it doesn't have to be an emergency for a farm worker children to be treated in medical, whatever, Medicity and other places. But I was really proud that evening about that. The second one is recently, and my firstborn is expecting a baby. All counseling course on the pregnancy, the do's, the don'ts, their whole education. When they were telling me that, I thought they were Medicity or some private, was my ignorance. But I was so proud that they were talking about our state facilities where they were getting this education about how to manage their pregnancy and what to be careful about and so on. So those are the two. There's many I can mention, but those are the two that I'm proud about our healthcare system. The two questions I have. The first one is, when we piloted the Basic Income Grant project in Omitara, we realized that before we did the payout, the income from the clinic was about 150 to 200 Namibian dollars. When people started to get the basic income grant, the income of the clinic jumped to 1,000, 1,200. And the sisters at the clinic were saying, we are not preventing people from coming to get the service, even if they don't have the money. But it seems as if that small amount of money is also still preventing people from accessing healthcare. Now, my question is the cost recovery maybe not too costly? How much is government getting from this cost recovery? And if we take it away, are we going to lose or are we going to gain? Because people, because they don't have this to pay at the clinic, they wait until the situation gets worse, and it might even be costly for government to treat. So you could, this is our clinic records, you could visit Omitara Clinic and see the changes that took place there. My final question is just we really, the 28 years that Mr. Kenjel talked about, for me as a citizen, it's really unacceptable that government took up to 28 years to sort out this issue. The challenges we are talking about are not insurmountable. It would have been addressed. We were told that the medical aid fund maybe is being paused so that we can consider integrating it in the universal health care. But that was like 10 years ago that this discussion started. And we really feel like the mere fact that government is not taking action on this, we feel betrayed that government is actually tolerating the status quo that is benefiting a very few. And we don't know whether the private sector medical aid lobby is playing a role here, but we really feel betrayed as citizens that it has taken 28 years for government to sort out a decision that was taken through an act of parliament. And we are hoping that at the 27th July meeting, we are going to make progress and that we are going to eventually start to put the process in motion to get a universal health care, which should be a right and not a privilege. Thank you.
One of the issues really that in a way disturbed me is from Mr. David Kenjere. I think for us to do justice to the issue in the country as far as health is concerned, we have to be serious. And what I'm saying, we have to be serious. If we have a manager, for that matter, who have been with Social Security for that long, and then when you stand in front of people, you think you say it lightly, it's a disclaimer, as if you are negating this possibility. I don't think that. We have to be serious with the issue, because Social Security Commission, there's so much they need to do to arrest this concern of health in the country. And then when you have an officer, general manager for that matter, I understand where you are in the rank of Social Security. I think, for me, I don't take that. And I think this is precisely the attitude that when you don't take yourself seriously to represent the institution that you are coming from. It's no, I want to say this out, please. Hear me out on this.
The ED to respond to the first two questions. The question from Stephen, is money the problem, or is the problem the allocation of resources? The issue of equity, the issue of effective and efficient allocation of resources. Then the last question from Mr. Franz, the issue of commodifying the provision of healthcare. Can we afford to let that continue as is? And then the last two questions go to Mr. Kenjele. Where is the sense of urgency in implementing programs that are already provided for in the Act? I think those are the two questions, both from Franz and Stephen.
The point of departure would be the very definition of what universal health coverage is supposed to be, and where it actually is coming from. Because universal health coverage is an international covenant where nations of the world came together.
We might broadcast this on TV, so if you can.
Yeah, where nations of the world came together and agreed that something needed to be done to ensure that those that do not have access to quality healthcare services are provided for. Being that a person should be able to access healthcare services without suffering a financial catastrophe. That is the basis. It was then seen that even in the context of resources that we have, for a country like Namibia, my brother Stephen painted a picture of the resources that are available to us as a nation when you look at the total health expenditure. As far as total health expenditure is concerned, government is still catering for upwards of 60, if not 63% or more. It's now how we rationalize the usage of these resources, because we recognize that the medical aid funds are catering only for so much. CMAS is catering only for so much. Then you have this underserved population, and these are the people that we need to pay. That is why the whole discussion on universal health coverage in Namibia started. As far back as 2018, when I joined the Ministry of Health and Social Services, we started the discussion. We started already holding discussions on universal health coverage. We sensitized the other executive directors in government to understand where we are coming from with all the stakeholders, including the Social Security Commission. In March this year, and we don't want to say this is because of COVID, and it was to some extent because when we started in 2019, of course COVID came, and that put brakes on what we were doing on the universal health coverage front. But in March this year, Cabinet actually approved the policy framework on universal health coverage. This policy framework is going to allow us to then have in-depth and wide consultations with all stakeholders. And we are going to lay all the cards on the table. We will not have sacred cows. Whether it is a private medical aid funds, whether it is SIMAs, whether it is employers, everybody must be able to contribute to that pool so that we improve the quality of public healthcare services. On the 27th of this month, we have the first consultations. And a lot of groundwork, or rather, background work is actually ongoing. We have enjoyed support from the World Health Organization that is supporting us in terms of providing us with consultants who are going to help us to hold this. But we are going to make this a public consultation process so that all of you can have your inputs, so that all the concerns can be raised, and we are going to have this as a Namibian product. That is how we want to approach it. And I just want to say that we invite you as stakeholders to come to these meetings with your inputs, with your concerns, so that we can hold this thing, make it the best that it can be, because we can. We can make it better. On the question of sustainability, yes, that is why we have these consultations. Please come with ideas and tell us how best we can do it. Let us bring the best ideas that we can come up with. The best among us must come and give us this information so that we can use it. On the question of the commercialization of the provision of public healthcare services, you will remember, or rather the fact of the matter is that the ministry or the government does not produce either the medicine or the clinical supplies that we use. We don't. So we have to procure them from somewhere. We have tried as much as possible, for example, to move as close as possible to the manufacturers. We have put in place a mechanism to ensure pooled procurement so that countries, for example, in SADC, buy together. You have the economies of scale, and then you can save money. But again, the moment you start talking about procuring directly from the manufacturers, you are accused of killing local businesses. And people are very angry when that happens. So we are trying to see how best we can do this in a very trying environment. The idea of public procurement is to get the best price, the best quality, and the best time of delivery that you can get. That is the idea of public procurement. And that is what we endeavor to do at all times. So, and it's not only the Ministry of Health and Social Services. Public procurement is such that where you don't manufacture a service or produce a service or an item, you have to get it from somewhere. So we are between a rock and a hard place. I trust that I have attempted to answer the questions. I thank you very much for listening.
Mr. Edie, if you can answer the last question from Mr. Uhuru, the issue of out-of-pocket payments that are required at the
okay. How can I forget that? That's very important. Actually, public healthcare services in Namibia are free, totally free. Members of the public who can pay a nominal fee. A nominal fee for your health passport, it is called. But you know that the moment you enter the ecosystem of the public healthcare system, you will, for example, depend, regardless of your ailment, if you come to a clinic and you happen to be diagnosed with cancer, for example, you are referred from that primary level to the highest tertiary facility in Namibia without having to pay anything else anymore, apart from that nominal fee that you pay. Also, if a person were to show up at a health facility and they do not have the $9 that they are supposed to pay, they will not be shown away. They will not be denied the service. We have made sure that already, for example, people living with disabilities, the communities that are regarded as marginalized, I don't know marginalized by who, they are not marginalized. The elderly, the war veterans do not pay, are not required to pay that nominal fee. But what we are saying is also this, and again, this is an element of universal health coverage, that those of us that can actually contribute, we should be able to contribute. Isn't it?
Through the tax.
No!
Yes. That $9 is preventing certain people from accessing timely the health service.
That's why I'm saying, my brother, nobody will be denied a service if you don't have the $9. Nobody. But if a Kaparachi Vikwa is running a business and he's earning an income and he goes to a health facility, he should pay that $9, right? Yeah, he should. So, but that shouldn't serve as a barrier to the provision of services at all, not for anyone. Nobody will be turned away from a health facility or denied service because they don't have the $9. Not at all. It's not a policy of the ministry. Okay. Thank you very much, ladies and gentlemen.
No, thank you. I think the reason why we're having this public debate is really to hear those views, and they are quite interesting. I want to address three things. Mr. Shioro is put I don't know whether it's a rhetoric question. Do we need an additional fund? And I just want to also then put back and say, are we having an equitable system of medical provision now? And if the answer is yes, then surely we are wasting our time to talk about an additional fund. I've explained what the parameters are for a national medical scheme. And I think the ED said those who are able to, they should be able to contribute. The contribution part, apart from the tax revenue, I think we have to look at it in different scenarios. As an insurance, you need at least to take some ownership and responsibility for what needs to happen in your life. And that's from that angle that you say it will help, because the current dilemma, the figures that we have quoted in terms of what the revenue is there to provide for healthcare, if we spread it, it's definitely not going to be enough. I'll leave it there, and we can still argue whether additional fund is needed. But how you source the funds is perhaps what is important. Mr. Uhuru, my friend, I think 28 years is quite a long time. And I want to go also to Tate France. Where's Tate France? Comrade France. If I was sitting there, I would have argued the same in terms of saying, why are you, what are you telling us if you're not telling it on behalf of the institution? Yeah, we have this situation where sometimes institutions send junior people just to listen and whatever. I'm not one of them, but I'm not a policy maker, and we can take the discussion in terms of where the hiccups are. I started saying that as a member of this group, the FESP, I have undertaken that I will be able to contribute to the discussion. And if we have to go to the bureaucracy and say, okay, send us somebody on behalf of the institution, sometimes it takes longer. This discussion, we can take it off again. But 28 years is just a long time. And I have tried to explain where the delays were. And there are structures, there are bureaucracies, and there are disagreements, there are lack of policies, and these things are not from one person. So we have to accept it, and that is why this debate should then be able to unpack those issues. I just put them as they are, not to represent any views, but I hope that they are useful. So I think those are the three things that I thought we'll be able to cover. Thank you.
We have 53 unemployment, which is 1.6, half of the population. And the same as only covers people that worked for the government. The unemployed people aren't working, to my understanding, yeah? Yeah? So, what medical aid is there for the unemployed people? Because they are vulnerable, by the way. Is there medical aids apart from, you know, the free access to the hospital and stuff? Will they get a lack benefit like the people get from the Lady Pohamba, the fancy hospitals? Will they receive such treatment? And well, Katutura Hospital, it's a pity, it's a shame. Rats running all over and stuff. I don't know. Same as, could it cover people that are unemployed in Namibia? Because we are half the population. Yeah, that's my question.
The issue regarded as the elephant in the room. The ED has left. He has requested for some input and solutions as to how to go about to introduce universal health coverage in the country. But I think that the issue of the elephant in the room, the issue about CMAS, the issue of what to do with CMAS vis-a-vis the National Medical Benefit Fund is, to me, the central issue to grapple with if we want to introduce social health insurance in Namibia and cover as many lives as possible under a health insurance scheme. I think that there have been several studies that has proven, including this one by the Economic Association of Namibia that Wayne was part of, that introducing the National Medical Benefit Fund without the CMAS lives is not financially feasible. Many studies have proven that. So I think that we need to grapple with that issue. We know that it is a politically sensitive issue, but it is central if we are serious, if we really want to bring a solution. And this study has covered examples from other African countries. I looked at Ghana, looked at Ethiopia, and looked at Rwanda. That is the way to go. Social health insurance is the answer. We have traveled to the world when I was in Social Security, and that's what we did. We found out that social health insurance is the way to go if we want to solve a problem. And therefore, even though we know that the issue is politically loaded and that it is a matter that really needs to be dealt with sensibly, we need to deal with it. And I hope that the ED will have that as a central topic, talking point at the coming stakeholders meeting. I think that is really what we need to do, and we need to bring in the Winners and Mahias of the world. We need to bring in the experts and look at the science, look at the statistics, look at the issues of spending and the issues of financial sustainability of a medical benefit fund that will cover as many people as possible. And if those statistics, if those analyses point us to the fact that CMAS need to be matched with NMBF, for example, that is what should happen. If that's what the science is telling us. Thank you.
My name is Sam Gawapilunga. I'm involved with one of the private medical aid funds. It's been very enriching listening to the various perspectives from the speakers. as well as the passionate views from the floor. I think, in essence, I would want to echo what my brother Konsi said. Look, essentially, health insurance, and you can use whatever jargon, whether it's universal healthcare, but the provision of health services comes at a cost. The bottom line is somebody must pay for it. So all these schemes and funds and stuff that we've been experimenting with all point in one direction, and that is, if we are talking about a fund which provides health services, which is run in accordance with almost insurance principles, which is regulated by various entities, including NAMFISA, that fund will operate in a very particular financial direction. It has to be run prudently. There would be solvency issues that will be imposed on those funds. And what that means in simple language is that the fund cannot spend all the money that it collects, otherwise it won't be solvent. And if the fund runs out of money, then the members must pay more. So I think this is the central issue here. There's been various studies done around the globe, including in some neighboring countries. I think the key issue, which one would hope would be addressed at that conference next week, would be the various funding models, which I would have hoped big institutions such as the SSC would have researched, the various options that it has uncovered through this research, and what we as a country can sustainably provide. In a private medical aid funds industry, the key issue that we grapple with in the boardroom is one: cost. That is the only key issue. We don't have a problem. Service is not a big thing. Utilization, which equals cost. Healthcare cost, healthcare inflation is a monster. It's driven not from Namibia but outside the borders. That is the monster. That is the issue that we must grapple with. Everybody understands the solidarity. Everybody understands the political jargon. We must engage the cost. Thank you.
Right. The very first question on the plight of the youth and their access to healthcare services. Then the second question on, so what's just your comment on the legacy that some people SSC also have left now that they are retiring? I'm not mentioning names. And then the question on CMS, is CMS untouchable or can it form part of the reforms, the necessary reforms? And then the last question now.
Very important question that was raised. Mr. Claudius Riruako. Yeah, so you rightfully mentioned, that in as much as we are saying that these mental health benefit fund would be primarily funded by people who work. We have a serious problem in Namibia in that not all people work. You mentioned an unemployment rate of 53%. Youth unemployment, I would like to add to that, is even more concerning. I think the stats for youth unemployment is hovering somewhere around 42-43%. Yeah. So this is really a huge concern you have highlighted. But again, what we are saying here is that the current status quo cannot remain, which is that we have a range of health services that need to be delivered to all people in the country, whether they work, whether they are employed, whether they are not employed. These health services need to be accessible to all throughout the span of their lifetime. It needs to be affordable, and it needs to be of quality. Now, I think there were good statistics that were raised, that were mentioned by my fellow panelists here about the sourcing of funds to provide healthcare. Currently, the budget for healthcare in Namibia hovers somewhere around 9.7 billion. That is not enough. This is why what we have done is only come up with a package of essential health care services. It is not an all-inclusive package, as I have mentioned. So we should actually broaden it. It should be all-inclusive. It should be of quality. It should be affordable. It should be accessible. And this is what we are trying to achieve with universal health coverage. Yes, the funding, the financing is a problem, but it's why the ED who left indicated that if there is a modality where we have those who are employed to compensate for those who are unemployed, then that's something we should explore. But as he indicated, it is something that is doable. We really just need to sit down, apply our minds to see how best, how best we can employ these modalities. But you are correct, and it's a point also that was raised by my fellow panelist here next to me, that perhaps how we do that is to explore the social health benefits fund, which will cater for all people, or will cater also to those who are unemployed. Yeah, so I think I have tried to address the question. I hope I've done so to your satisfaction. But really, it is just to say that let us explore these modalities together. We have a very wide stakeholder engagement that is coming up. Again, I repeat it, at the 27th of July. Let us continue the discussion. I thank you.
Your final word, 30 seconds? Done?
Yes, in 30 seconds or less. I think really my ED has covered everything very, very well. But I think what needs to be clear here is that Namibia needs to achieve universal health coverage one way or the other. The current status quo cannot remain. And the COVID-19 pandemic was a stark reminder, of the existing inequalities that there are in our society in terms of access and affordability to quality health care. It's something that should be premised on building and strengthening our health care systems. The funding, as has been mentioned, the financing is the elephant in the room, but it is not an insurmountable task. It's something that we can apply our minds to, but achieve universal health coverage we must.
Thank you. Thank you so much. 30 seconds.
Yeah, thank you for having out to be able to do that. In one of my slides, I talk about the issue of strong leadership. That means, I'm not saying weak leadership is currently the situation, just in terms of driving these things, is what is needed. And perhaps I take note of the issue of legacy, and this is something that we need to take. Whatever we are doing here, we shouldn't just have a talk show, but rather making sure that we move from point A to point B and point C. That's what has been lacking, and it's quite frustrating. I'm just happy that I'm leaving. But anyway, that's just on the lighter note. The issue of CMAs is a tricky one, because I'm not too sure. We are just doing an assessment in terms of what is feasible, what can be done, and this is just to contribute to the public discourse and debate on the issues and understand them. My failure, I think this evening, was if I was unable to say that there is an element to consider and align the things in terms of the priorities. Do you want to start with universal health care and then we move back, or should we first start incrementally going on? And that didn't feature through, and it looked like that's something that I do believe in the next session I'll not be shy of again highlighting that. And lastly, the issue of cost is scary to everyone, especially now. If you talk about the cost, I think whoever was listening, we think about transport, petrol, food, and everybody is now, the cost of medical, the ED was saying, is driven from outside. All these things, they are quite scary, and it's not an easy topic to deal with. But I'm happy that we're able to discuss, and I really enjoyed the participation of the members. Thank you so much.
Thank you very much. I think a lot of points have been raised. I think pointing out the efficiency of service delivery is important as we move forward. I know we spend a lot on health, but I think the delivery somewhere, somehow, I think we need to dig deeper to understand where